I want to welcome you to the CEDER Learning Exchange. We're delighted today to have Dr. Osagie Ebekozien, who's going to present an update from the ADA on standards of care in overweight and obesity. Next slide, please. Oh, good. Oh, on behalf of many of everyone in the CEDAR Center and my fellow PIs, Nadia Islam and Earl Chambers, and the NIDDK, we want to welcome you. It's great to see so many of you here. It's also wonderful to have Dr. Ebekozien here to close out our first year of these sessions and help launch our new partnership with the ADA. As you all are aware, November is Diabetes Awareness Month, and it's dedicated to enhancing awareness for prevention, detection, and management of diabetes and its complications. And we thought there would be no more fitting way to acknowledge this than to have the ADA as our partner here today. So what we're going to see on our agenda on the next slide is the day will be a brief welcome and overview by me, followed by an introduction of Dr. Ebekozien by my colleague Tanaz Moeen. And following his presentation, we will have some time for Q&A. So we look forward to that. I want to just spend a little bit of time describing CEDER. Many of you may be well aware of what CEDER is and does. But if you could go to the next slide. CEDER is the Center for Engagement in Diabetes Research, and its main goal is really to provide resources and technical assistance to promote engagement, research, and programs related to type 2 diabetes. Our consortium seeks to foster community-led and community-informed diabetes research, integrating multi-sector engagement across the research spectrum. In the past several months, we have built a collaboration with the American Diabetes Association. And if you go to the next slide, you'll see that we are now officially partnered with CEDER, with ADA as a member of our partnership hub. We'll be collaborating on these learning exchange trainings and webinars, and we'll be providing expertise for CEDER consultations and studios, and also identify experts outside of our network who can participate in those. We'll also be having a joint promotion of ADA and CEDER events, resources, services, and programs. Next slide. So the learning exchange, the goals are really to share examples and best practices of positive research and community partnerships that highlight community engagement in type 2 diabetes research and programs. We want to increase understanding and expertise around policy, communication, grant writing, community-based participatory research, and a range of other topics. The participants, this is open to everyone. So we have many CEDER Partnership Hub members and clients who span the country, and also any individuals who are interested in type 2 diabetes research and community engagement. We welcome those particularly who are funded by NIDDK and want to incorporate more engagement in their projects. So I'm now going to pass the baton to my colleague, and I want to welcome Dr. Tanaz Moeen, who is a member of CEDER, the UCLA Community and Stakeholder Engagement Core. Dr. Moeen, as many of you know, is an endocrinologist and health services researcher at UCLA and the Greater Los Angeles VA. She has many, many roles here, including as co-director of our CTSI's KL2 Translation Science Scholars Program. And she has extensive expertise in comparative effectiveness, pragmatic trials, and implementation science. She serves as principal investigator on several grants, and is the founding director of the University of California Office of the President Diabetes Prevention Program. And in this role, she's led efforts to address diabetes and obesity across all 10 University of California campuses. So I am now going to pass the baton to Dr. Moeen, and welcome.
Thanks so much, Dr. Brown, and good morning or good afternoon, depending on what side of the country you're on. It's really a pleasure to be here and have an opportunity not just to celebrate, November Diabetes Awareness, but also just this great partnership that Dr. Brown highlighted, the work of CEDER and the work of ADA. I feel like those are beautiful harmony and synergy in what we're going to talk about today. So I have the pleasure of introducing our guest speaker, Dr. Osagie Ebekozien, who many of you know is the Chief Quality Officer at the American Diabetes Association. In this role, he leads ADA efforts to transform diabetes and obesity quality outcomes and improving access to evidence-based practice. He most recently served also as the Chief Medical Officer for the Type 1 Diabetes Exchange based in Boston. In that role, he was leading diabetes clinical affairs, quality, equity, and population health improvement. And prior to his time at the Type 1 Diabetes Exchange, he held roles in primary care transformation, obesity, and type 2 diabetes management in several capacities. He's a recipient of many awards, including the 2024 James Reed NMA Outstanding Physician Award, the 2022 Eli Lilly Leonard or Diabetes Research Award, as well as the 2021 International Pediatric Diabetes Innovation Award. And others. So he's co-authored over 100 manuscripts and is a frequent speaker at professional conferences, and it's really a delight to have him here with us. And I'm going to ask him to please get us started. And we have another slide in terms of the learning objectives. We're going to review ADA standards of care in overweight and obesity, discuss implications of standard of care on research and safety net settings, and overview of the ADA Obesity Association. So Dr. Ebekozien, I'll turn it over to you. Thank you.
Well, thank you, and I'm truly appreciative of the opportunity, and I'm looking forward to the great conversations we're going to have today as well after this presentation. And on behalf of ADA and the Obesity Association, we're honored to be able to collaborate with CEDER and collaborate on the great work that we'll be able to continue to lead together as relates to type 2 diabetes and obesity. I think that folks might have a question on like, well, this is CEDER and we're focused on diabetes. Yes, and CEDER is focused on diabetes, but I'm preaching to the church. I'm preaching to the audience that for data we already know that obesity is one of the largest drivers of type 2 diabetes in our community. So for us to address the second component of CEDAR's goals on the risk factors of diabetes, we can't ignore obesity. It's the elephant in the room, and we need to be able to think about that in our research lens, think about that in our implementation efforts, think about that, how it impacts the outcomes of obesity too, because they are so connected and so married together that we can't ignore the importance of that. So that's going to be an overall recurring theme you would hear in my presentation. It's as you lead type 2 research and as you work across the community around type 2 implementation, what role it's obesity and obesity standards and obesity conversation having in the core work you're doing around type 2 diabetes, irrespective of what your focus is, because that's the main message I'm trying to get across is you can't ignore the importance of obesity in implementation in type 2 research, and they are too connected to with each other, and you would hopefully see some of that. So I can advance to the next slide. ADA, we've been in existence for 85 years, and many of you have been members of the ADA, professional members. And I've seen a few of some of the names that are registered for this webinar and conferences, ABA Scientific Session. The last was in Chicago. Hopefully we'll see a good number of you in New Orleans in 2026. ADA has been a trusted voice in the diabetes space for 85 years. Fund a lot of research efforts. They fund millions, invest millions in research dollars in diabetes every year and diabetes prevention and management. So what you're seeing on this chart here, it's our strategic priorities. We are a big proponent of advocacy. education, and then, but a lot of what I'll talk about is in the connect pillar, which is how we improve access, how we work with communities, work with providers, work with researchers, and connect people living with diabetes and obesity to ensure the best outcome. So that's I'll highlight the standards on the focus area. So one more click there will highlight obesity. So there's diabetes prevention and management, which is an important part. And if you advance the slide, it should highlight health equity, health access, and obesity too as well. So hopefully you would see in the course of the sharing how there's the shared priorities between many of the efforts that you're leading as researchers in the type 2 space and what we are doing at ADA to really move these standards into practice and into research to support all of your efforts too. Can move on to the next slide. So I talked briefly about this at the start of the conversation. This is not news to anyone. I'm sure some of you on the call, webinar too, might have been involved in different kind of research around the interconnection between diabetes and obesity. But the headline, it's more than 50% of new cases can be attributed to obesity. So that's if we have to address risk factors and complications and prevalence of type 2. We need to be more intentional around obesity, and what I will share is what's the ADA's position and what's our standards around obesity. I would provide examples of that. I encourage everyone to go back and actually I encourage you to read more on some of our guidelines on obesity and the importance of that. Chapter 8 of the ADA Standards of Care. It's all focused on obesity. It's freely available on our website. You would see me reference some tables there, but and I think our CEDER friends too can share the link to that too after the webinar as well, because it's such an important component of a lot of what I'll talk about in the next few minutes. And we can move on to the next slide. So what we're striving to do at ADA is to support people wherever they are, support them at home, support them at the community, support and when we think about community, both in the physical community and the digital community, we have quite a lot of programming and research studies and research support, also exploring the digital community or the virtual community and the role of that, and also in the same way to the physical community. And then primary care and understanding the impact of primary care. We describe primary care as the first and the last mile for our work. And for a lot of the research work I'm sure you all are leading to, it's how do we get that into the hands of primary care providers that care for more than 80% of people living with diabetes and more than 80% of people living with type 2 diabetes. And and then obesity too as well. A lot of primary care providers are the first mile or the first step in the door. So how do we support primary care providers, even from a research lens, and a research perspective? How do we engage them in our trials? How do we help them be a partner in the work we're trying to do collectively in the diabetes research community? And then what's the role of specialty care? We see our friends from NYU, from UCLA, from all of the great institutions across the country. And in some of the specialty care spaces, what's the interconnection between that and research and primary care? And so for us at ADA, our goal is irrespective of where people are and irrespective of what door they are entering or where they are in their journey, how do we truly support them to improve access and improve quality? And if we can answer those questions, that's the drive, and that's what's pushing us to do what we aim to do every day, and that's what we wake up to do. And really excited that we get a chance to collaborate with CEDER and many of you great minds on the webinar today to truly answer that question on it's our research, the research efforts and the work we're doing improving access, or the findings from that research, how can that support improvement in access? How can the insights from our research and the activities we do support improvements in diabetes quality and outcomes? Because I know at the end of the day, that's what matters to all of us as researchers is the insights we would gain and the knowledge we would discover. Can that lead to improvement in outcomes or improvement in access to really make lives better? And I'll talk some more about this if we advance to the next slide. So talked about this chapter 8, and this is if there's one thing you take away from this my presentation today, it's please take a look at this chapter and read through it, a few pages. But if you know in your core research in the type 2 space, I'm sure you would find a lot of the insights here are valuable and potentially help you in trying to answer some of that questions of intersectionality. For the past 35 years, ADA has provided the diabetes community with national guidelines, so national standards. Every December, the new standards come out. So next month, there'll be the 2026 standards, and chapter 8 would highlight what's the latest and greatest for the research. And I also want to thank many of you because the research you do and you lead and the clinical trials and the studies and the pragmatic studies, all of those efforts every year, the ADA team spends time scanning all the literature, looking at the meta-analysis and the systemic reviews, looking at all the original trials being done in type 2 diabetes, many of them led by you. We synthesize all that information and look at, based on the result from the research that you're leading and the efforts you're leading, where are we now in terms of of specific recommendations? So every year, about a third of our recommendations are new. We discontinue some recommendations based on new research, based on new evidence. We modify some recommendations based on new research and evidence, and then another third of that gets kept as is. So one of my message with that is, as you're leading your different efforts in the research space, to think about the questions you're trying to answer. How will that also help associations and organizations like ADA that is thinking about the guidelines and thinking about the recommendations and thinking about the field? How does the work you're doing and the research questions you're answering, how will the results and the insights you gather from that, how will that help us to come up with better standards, to come up with more responsive standard? Because our team spends months looking at all of those research findings in the previous year to inform those guidelines. So the work you're doing, it's meaningful. But more importantly, I think we also share this on the sort of the inverse on as you're implementing new studies and answering new questions, how are you implementing or trying out or involving research to understand how some of these recommendations are being implemented in practice, or understand how some of these recommendations are happening in the real life, or understand some of the dynamic components that will make these recommendations truly sustainable or not? So on this table, I give you a few examples of what some of those recommendations are like, and the chapter sort of details a lot more of them. The letter grade there, it's the strength of the evidence, and A being the highest strength. So I'll just read one. In people, 8.4 standard recommendation in people with type 2 diabetes and overweight and obesity, the weight management should represent the primary goal or treatment alongside glycemic management. That's from ADA on. We see the importance of managing weight, and that needs to also happen alongside as we think through managing type 2 and getting the A1C under control and getting all of the different components we as researchers think through on our interventions is impacting glycemic goals. But to ask the question of what's the potential for intervention to help with overweight and obesity management, because those are critical components of that. So as I was thinking about this presentation, I think can our second aim in our research objectives, if the first one is centered around glycemic outcomes, glycemic management, can there be a second aim centered around obesity in that for a subpopulation of participants in our research work? Because all of that interconnection, it's a very strong one, and we want to see more type 2 researchers think about weight and the importance of that the same way you think about glycemic outcomes and glycemic management. And then, there's a whole lot of other recommendations here. I won't go through that. The next slide also highlights a few more recommendations if we advance to the next slide. And then just again, my point with this is think of a lot of the critical issues you might think of on I'm trying to do a study on GLP-1s and type 2 outcomes. I'm trying to do a study on diabetes technology and type 2 outcomes. For a lot of that, once you go through Chapter 8 and the national recommendations, you would hopefully see potential second and third aims that you can consider in your new proposal, or consider in your sub-analysis, or consider as you think through sensitivity or any of the other different components, even if it's post the grant initiation phase and you're in the data analysis. There are some questions that there might be room as you think about the sub-analysis or any of those other components to sort of consider what's the role of obesity, what's the role of BMI, what's the role of weight, body, as it relates to some of the core primary outcomes or primary goals of your studies as well. And then I share a few more examples here. Big picture, there's a lot of great recommendations, great insights that I'm sure you would see potential alignments with the work you're doing as it relates to type 2 research and the interconnection here with obesity. But we know it moves beyond just what the recommendations are, and it moves beyond what's happening in the obesity space. If we move on to the next slide, stigma and bias is a very important component, and you see a nice figure on the next slide. If you can help advance that, thank you. So stigma and the importance of that, it's another key message that we've been trying to emphasize at the ADA. And that we also see the need for more research studies that looking at type 2 diabetes and weight and obesity. There's a lot of room for us to explore for patients with type 2, and we're designing interventions to address type 2. What consideration are we making to stigma and weight stigma, and how that impacts some of those outcomes too as well. In this table, this figure that's on the and the Chapter 8 of that I just talked about, and the standards of care, it's on our website. You can find the ADA standards of care, diabetes care, our flagship journal. So we sort of examine and draw that part on the impact of stigma and stress and sort of that recurring loop, and how that even contributes to more of the challenges we're trying to manage. So to address some of that, that's the Obesity Association at ADA. Obesity Association is a subdivision of the ADA, and our whole goal is to bring in more intentionality and more focus to the interconnection between type 2 diabetes and obesity. But even and sort of that where all that intersection sort of fits in. So one of the new products coming from the Obesity Association, I'll share that in the next slide. It's specific standard just to as it relates to critical things like obesity alone and weight stigma and bias, and how do you respond to that. So BMJ and ADA, we co-publish guidelines and standards specifically on stigma and bias. Again, drawing the importance of that, the critical need for us to address some of this, to think about that in our research work, and more importantly, think about how do we address this? How does what we're doing impact some of that? And these are, again, some recommendations in this. And we'll be sure to send the link to this paper alongside the link to the Chapter 8 I talked about to our friends at CEDER. So everyone registered on the webinar will get access to that. And it's all free resource. And we encourage you to take a look at it and then, sort of explore some of these concepts I've described in a lot of words so far. But these are some of the recommendations as it relates to addressing stigma and the importance of that. From a research lens, where we see this, and speaking to research-minded colleagues, we're seeing this more of confounders and how it's bias and weight stigma, a potential confounder in some of the outcomes we're thinking about, and what role are they playing in the clinic, if we're exploring for that. So my hope is to really help expand, if I may, understanding on how our core research on type 2 diabetes can be very heavily impacted by obesity, and encouraging us to bring that closer, bring obesity and obesity management closer into our work around type 2 diabetes research. So with all that, what do we do about it? How are we implementing these standards into practice? What change are we making? And I'll describe a few of that before we open it up for questions and answers. And we're going to advance to the next slide, please. So we know a lot of these insights are great. These recommendations are great. There are over 600 recommendations in the ADA standards. But the reality is many of those recommendations don't reach patients. And many of you have seen this figure, and you're leading the science, you're leading the research. A lot of that research doesn't even feed into the standards of care. We're trying to do a better job in ensuring that the research gets to the standards. But we know there's more to be done. But even when it does get to the standard, how do we ensure that that gets to care and address some of those variability in care delivery? Because you're taking all that effort and you're doing all of the great work in the research lens. We want to make sure that the science you're generating truly gets to more than 30 million people living with type 2 diabetes. And that's part of our mission and goal and what we're working towards. And I'll describe a few ways we're doing that in with the hope that we can continue our collaboration and efforts to get more of this science to the patients that have the most need for all of the great insights you're uncovering. Okay, move on to the next slide, please. All right, so that's what this is. This is a framework, a broad framework for how we're doing this work. We start by looking at what the relevant standard is, identify where gaps are, think about what we can do, collaborative interventions as a pragmatic. And this can also be in a research lens as well, an implementation lens or an implementation study if you're a hybrid design and any of that. A lot of what we're doing in implementation science and pragmatic studies, can really sort of come into light with these efforts as well. Think about what we want to study, and then if it's successful, can we scale it and ensure that we're looking for ways to sustain that effort? And there are a few groups helping us do that, which I'll highlight and can advance to the next slide, please. So this is where the primary care piece comes in as we think about implementation and bringing those standards into practice for diabetes, type 2 diabetes, and also for obesity and the interconnection between both. We at ADA are working across around the clock to think about implementing these objectives. These are all objectives approved by the ADA board. And a lot of what we're doing is prioritizing new studies that are looking at implementation for primary care for obesity and type 2 diabetes interventions. So those are areas that we continue to be laser focused on because we know if we can work with at the primary care level, where 80% of people with type 2 diabetes are being seen, that gives us a big chance to have impact on millions of lives. We love our friends at UCLA and NYU, and they're doing a great job here. And they're also supporting a lot of primary care centers across the country. So part of our excitement with working with CEDER, it's sort of thinking about how do we go broad and large to take this insight from all the great institutions, take it across to primary care center in Oklahoma or in North Dakota or any of the other groups that might not have the same sort of resources like other centers might. Can we test interventions there from a research lens or implementation lens in a setting like that, and to help us feel more confident around how we can push this and think about policies we want to champion, expanding knowledge, empowering people. And all of this as objectives as they are here can literally also be objectives in some of the studies and they probably are objectives in a few studies some of you might have from a research perspective. So, and if they are, we want to hear about them too as well, because we want to sort of stay close to the great work you're doing and ensure that that science can lead to standards, which can lead to improvement in practice as well. And you can move on to the next slide, please. This a list of organizations nationally that ADA is working with to take all that science that you're generating and the standards in type 2 diabetes and obesity, all of the things I talked about for the last 20 minutes or so. We're working with these national associations to educate and support their own stakeholders. So AANP, the Nurse Practitioners Group, they represent hundreds and thousands of nurse practitioners across the country, or physician assistants, AAPA, ACP, our physician colleagues, diabetes educators. These associations represent different members of the diabetes care team So for us, it's critical that we're intentional around taking all that great insights and working with these national organizations in advancing that science to their members, to our colleagues, to our friends, to all of the different groups they represent. And this is one way we're doing that. And I'm more than happy to share some more about that. But why I wanted to highlight this here is that it goes beyond ADA alone, it goes beyond CEDER, it goes beyond NIDDK. It will truly take all of us to get to the outcomes we want to see in type 2 diabetes and ensure that our research efforts and insight gets to patients. And for us at ADA, we see our role as a convener and bringing groups together, national groups like this. And that's what we're doing now to bring insight in from obesity and type 2 diabetes and to the provider community with great partners like this represented on this slide. And we can move on to the next, please. And then we're testing out different pilots, like talked about. There are over 4,000 practices that are part of our network, where we're testing out different implementation studies, exploring type 2 diabetes and eye disease, type 2 diabetes and chronic kidney disease, type 2 diabetes and obesity, type 2 diabetes and technology, and we can keep on going off the list. But for us, we want to test this in the primary care space. We want to make sure it works. We want to make sure that a single primary care provider or a large primary care network, they feel like they can be part of that solution and implement those pieces. And we're doing that through a group we call the AD Alliance. That is also a resource that continues to expand and gives us real world insight into what is happening every day in the diabetes and primary care space as well. So another example of how we're doing this in real time. I can move on to the next slide, please. Right, so one example, more practical example, now we're working with 500 primary care practices, and my colleagues are on this webinar as well. And I'll give a shout out to them, Karina and Melissa. And they've been working across the board to ensure that some of these resources, the best practices, the recommendations, the guidelines can be implemented. And we have an ambitious goal of doing this across 500 different primary care centers in a very pragmatic study. So we're exploring different interventions, and we'll be publishing on this too and our insights here. But I share this as one example, and you know, my guess is many of our colleagues too on the webinar or friends that might be listening to the recording, you might also be involved in large scale type 2 diabetes, obesity, primary care or so interventions. We'll continue to look out for the insight from your work, because that way we can continue the learning, the sharing, which is the whole goal of the CEDER community and this learning series that Dr. Brown, Dr. Moyne, and the rest of the group at CEDER, are putting together. So this is part of what we're doing as an example, but we also want to learn more about some of the great things you all are doing. And we can move on to the next slide. All right, health access and expanding access. I talked about that and the importance of that. Specifically, I want to underscore that a lot of type 2 and obesity, type 2 diabetes and obesity, we see a lot of those impacts too in many of the underserved communities. So how do we think about that intentionality too in our research design, in addressing gaps, in addressing barriers, and how do we think about the community-centered research, which I know CEDER stands for too. And so you see these objectives here. None of this will be surprising. I'll give you a minute to sort of think through that. But as you read through these different objectives, advancing inclusive research, supporting communities, equipping professionals, acting as a convener, these are goals that our ADA board has approved. But more importantly, I think there are also goals and objectives that many of you might have written into your R01 or written into some of your other research endeavors as well, because they are broad enough that my guess is there's a large consortium of colleagues working on similar kinds of goals. And for us is bringing this same access lens into our work around type 2 diabetes specifically, and the impact of obesity as well there too. And we can move on to the next slide. And we are also taking this to the community and doing real world efforts too. And some of my colleagues too, Natasha, Tiffany on the call, are working to take the insights from our standards of care, from obesity standards, bring that to the local community, working with community, what we call our community hubs, to empower people on the ground, to support them through that. And then we'll be publishing and sharing insights from this work too as the work evolves. So my goal with sharing these examples is the research efforts, implementation efforts, we see the importance of understanding what the guidelines and the standards and the recommendation call for, and thinking about how does our research help close the gap there? And if it does, how are we sharing that to ensure that it makes it into a standard and then it impacts the community at the end of the day with the recommendation? We can move on to the next slide. And I think I have a few more. And then finally, quality. Whatever we're learning, whatever insights we're uncovering, and my colleague Melissa too, I believe is on the call, and Holly and others, insights and key things we're learning, we're intentional around how does that go beyond just it being in a research lens. We know it's important, but how do we sustain this, make this part of our quality infrastructure, make this part of our ongoing quality efforts here? And these are the objectives in this case that we're working towards to really support all those efforts. Can we lead to broader dissemination and implementation to ensure that your research efforts can be sustained from a quality lens moving forward? We can advance, please. All right, so this is my last slide, and I have talked about a lot of things, and I started sharing what ADA, who we are at ADA, gave insights into from 85 years of ADA's existence to 35 years of developing guidelines and standards, and that many of you are aware of, to the last 2 years where for us, we had to develop the Obesity Association as a division of ADA to really bring in the intentionality around type 2 diabetes and obesity. And then I went on to describe how our team at ADA is taking these standards, working across primary care to implement them, to test some new pragmatic studies there, working across access to think about what's the role of community and testing different interventions there, and then finally working across quality to push that needle. But my big message through all of this is that as you think about your type 2 studies, type 2 trials, can your second aim or your sub-objective or your secondary outcome be something centered around obesity and overweight, because the interconnection is so critical, and all of us as diabetes researchers, our call from ADA is to actively consider the role of obesity and overweight in your ongoing study, whatever it is, because there's a very high chance the impact is stronger than we might be reporting now. And we hope that you will appreciate that and be able to go on that journey to it. So thank you again to the CEDER team. Look forward to the questions and conversations afterwards.
That's wonderful. Thank you so much, Dr. Ebekozien. You covered a lot of ground, and it sounds like there's a lot of really exciting things, both, of course, with the ADA standards of care and then ADA obesity and some of the initiatives that you talked about. So we're certainly going to have folks put questions in the chat, and there are some that have come in, and we can get started on one of the questions. Actually, you talked about the Obesity QI Roadmap Initiative,
Yes.
Which sounds really exciting and is sort of just getting off the ground. So if there are private or public primary care practices or groups, how do they become involved? Are there opportunities for folks to become involved in this QI initiative that you described?
Yes, they are. And I've just put in the chat the email address to indicate your interest, and quality@diabetes.org. A member of the ADA team will be on standby, ready to answer any of the questions you might have, or walk you through how you can be a part of that and how you can join that effort. So that effort is just starting now. So quality@diabetes.org, that is the email address to reach us, and we can provide additional information on how you can be a part of that.
That's great. And especially if it's something that is just getting started, I guess this would be the time to do that outreach. And it's wonderful that ADA is making that opportunity available to folks. And another question is really about sort of blending a lot of what you've talked about in terms of access and quality, and the work and sort of the focus of CEDER in terms of community-led and community-informed research in the type 2 diabetes and obesity space. And I was just wondering, this is sort of a big picture question, but when you think about community-led, community-informed research, what would you say are sort of like the key, priorities, one or two areas? There may be several, but are there things that come to mind right away for you and the work that the ADA is doing?
There are several. And I will start first from the obesity space and the obesity lens. And we see that as a very good example of community-led intervention and efforts. And what we're doing now, we're working across five different communities. We're working in Delaware, Kansas City, Missouri, working at and my team will be like, I can't believe you're blanking out on the names of the other communities now. But I'll zoom in on Delaware and Kansas for a second, because the work we're doing in those communities is empowering and identifying some of the key stakeholders and community groups. San Bernardino is another, and that just came back in California. And what we can do is we can also share the different communities we're working on, and we can share that with Dr. Moy and your team, and for colleagues that are in those communities that want to be a part of that, they're welcome to take a look at that. But big picture, to zoom in on Delaware. So at Delaware, we're working now with not just community-based organizations, but like the public health departments, their primary care associations, the community-based organizations. And the goal of it is when we prioritize obesity from a community lens, from a community level, how do we as the community, including the voices of people living with obesity, overweight, think about what sort of efforts, what sort of improvement efforts, implementation efforts would truly help us move the needle within our community. And then we use implementations framework like the CIFR framework to really think about what's happening inner context, external context. What are some of the things happening within this community that might be driving some of the responses or non-responses to the issues we see? So for us, is no two community will be the same. San Bernardino is not going to do the same as Durham in North Carolina, and that will be very different from Delaware, very different from Kansas, very different from Atlanta. So for us, it's really being clear on there won't be any similar community, but can we think about insights that if we're trying this in 5 communities, perhaps might be similar, and if that's the case, we can inform the piece on communities will be different, but we've seen this component that are the same, or if it's all different, also still reporting on where do we see all those differences and how do we think that as we go on and make interventions at the community level. So we're doing that now in the obesity space. We're also doing that in the eye care space, diabetes retinopathy. When we think of community interventions, we're looking for specific things that community partners can play a role in. They can host a workshop, they can host a screening venue, they can provide educational information. So where we see those opportunities that the community organizations, community members can have a key role and beyond just giving us your feedback, but actually have a more meaningful role. Those are places that we intervene. CKD, chronic kidney disease is another. We're doing that. And we have community that is helping with doing education, but also doing some of the screening efforts there, helping us with UACR or EGFR screening, and sort of connecting community members to those resources locally. Those are all things that get us excited about being there, being on the ground, and actually helping inform what we learn in a real way.
That's fantastic. And it's sort of, I mean, what you're touching on is not just the community-led, community-informed principles of doing the work, but just that, lessons learned in terms of implementation of the standards and best practices are going to vary, right, by the communities that you're working with. And sort of on the sort of area of implementation science focused projects or funding opportunities, one of the questions we had in the chat was just asking about whether, is the ADA thinking about new research funding opportunities to examine implementation science and dissemination research in this space? Is that something that is on the horizon?
Yes, it is. It is on the horizon. What we can also share, Dr. Moin, with your team is we can share a link to current funding opportunities already that open at ADA. Many of the funding opportunities right now are looking at primary care and implementation in primary care and efforts around supporting research in that. So, and want to share that link, and it's on our website, but we'll share the specific links so it's easier to navigate there with your team. But yes, there are those opportunities, and then in 26 and beyond, there'll be a lot more opportunities sort of focus on the broader implementation space. But for now, there are research opportunities on primary care and supporting primary care and the lens on that. A lot of that is already publicly available.
That's fantastic. And that actually sort of brings me to the ADA Diabetes Primary Care Alliance. As you said, it's so important, I think, to bring together the different groups, right, who have enthusiasm, passion, and are obviously working with the patients and communities. So tell us about, I guess, in terms of the Primary Care Alliance, kind of what are are they also working in these 5 communities that you just mentioned? Is this kind of all overlapping with one another, it sounds like?
It's overlapping.
Yeah.
There are large primary care networks working in those 5 communities. But our Primary Care Alliance, we're involved now in 9 different implementation studies with the Alliance. So they're involved in diabetes technology and involved in CKD and obesity. So the team was even able to find
Yeah,
that.
they're
So thank
putting
you,
them.
Sarah. That's good. And that's the link, 2026, 2027, where new opportunities will continue to be updated as well. So that's a link to bookmark as well for our friends, because it will be the fastest way to know what's new and in terms of research space. So, but back to your question, the alliance is all across the country, and these are primary care centers and large networks, I should say, that have a lot of interest in implementing these standards in their practice or across their network. So for us, it gives us a chance to truly test something in real time, see how effective it is or not. And we embrace that. We actually want to know more about what's not working. So if it's not working, let's cut that really quickly and learn something that might work, so that we can all learn faster. So yes, it is. It's across the country, and there's room to be involved in that too. If you're a member of a large primary care network, quality@diabetes.org is the fastest way to reach us. The email I shared earlier, and just indicate your interest and let us know a little bit about your network. And someone from our team would reach out and share the form and all of that kind of those pieces. But just an email, and then our team would take care of some of that if that's of interest too.
Absolutely. That's great. And again, thank you for sharing all of those resources. And, when you talked about the ADA Diabetes Primary Care Alliance, you mentioned, I think on the slide that you've oversampled rural and underserved communities and FQHCs. And so I think one of the other questions is sort of what do you feel in the experience you've all had with this alliance so far might be the key considerations for those working in safety net settings. Many of our partners with CEDER are particularly focused on safety net, providing, again, the highest quality of care despite the challenges that are so prevalent. But share with us any insights you have gained so far.
No, it's a great question, and it's one that we approach with a lot of humility, because we're also trying to learn as much as we can, and in a resource in a limited resource setting too. So I think for us is one of the bigger spaces, the simpler the better, like the importance of simplicity and the more resource constraints of practices or centers, the more important our interventions, our efforts need to be as simple as possible. And I know as researchers, we love the complexity of, oh, let's add this and let's add that part. And what if we incorporate this space? But that's where if it's going to work, then it needs to be something very, very simple. So, I don't think that's very profound, but that's one thing that keeps coming up of like, well, Doc, this is way too much. You're losing me here. So how can I go to make it even more simplified and make it to a level where, and then the other piece is incorporating existing system. So a lot of the interventions now we think of, okay, can we do a clinical decision support piece with this, or a BPA, best practice advisory in the EHR, or can this be done during incorporate this into the check-in process? So we're just really finding an already existing system and looking for ways to further simplify that to introduce our intervention and introduce what we're trying to study. And the simpler is sort of the recurring theme on, I need to be able to explain it in a second, and I need to see if it works or not because we just don't have that luxury there.
Yeah, no, such good points. We always say, what they can do in a randomized trial is not, it's, when we're talking about the real world, it's complex, it's messy. We need pragmatic, feasible, right? And really reasonable to implement strategies that we believe are going to be effective and in all real world settings, but particularly our safety net places. So I know we're getting to the top of the hour here, and I just, I have to say that it's been really a pleasure hearing about all of this work, and I was going to pass it back to Dr. Brown to help us close out the webinar this morning.
Terrific. Well, I want to second Dr. Moeen's thank you. This was really an amazing talk. I feel like I learned a huge amount, and it was wonderful to learn about the emerging ADA emphasis on real support for patients where they live, work, play, and pray. And for the primary care providers like myself who are on the ground trying to do this work, the support that you are providing is really critical. So thank you again. I think we have put in the chat a lot of the links that you described, and I hope folks have access to them. Sarah, thank you for doing that. We want to make sure that we get your feedback. And so there's a link here on this slide, and it's also in the chat. We ask you to take a few minutes to complete the survey using the QR code or the link. Your feedback is really essential to the Learning Exchange series. It'll really help us do a better job of identifying topics, of improving the work that we're doing, and figuring out who to bring to the next meeting. I'm gonna let you guys have a little more time for that, but also want you to know that you can request a free consult or a studio from CEDER. This is the process by which you do it. You can go on our website, or you can go to this link. You fill out a form. It's actually very quick. For people who may have tried to fill out the form in the past, it was a little longer. We got your feedback, and we shortened the form. And then we have a brief introductory meeting within the next couple of weeks, within a couple of weeks of your filling out the form. And then we work to connect you with subject matter experts, and those may be folks in the academic setting, they may be community members, they may be agency leads. We really want to identify the people who can help you move your work to the next level. And we are delighted that we now have the American Diabetes Association as part of that process. On the next slide, you'll see ways you can connect with CEDER, so through social media, through these learning exchanges, and then we also have a quarterly newsletter. And then you can email us or go to our website. And then definitely, as you know, you can always connect to the ADA. You can download the ADA standards of care through this link, and then we also have the link in the chat. And then there's the links also go to the obesity initiatives as well. Please take a minute to download those items. So I want to finally want you to make sure that you can visit CEDER. Here's another QR code. But again, thank you for taking the time to join us today, and we look forward to meeting you again at our next learning collaborative meeting. And we really want to again thank you, Dr. Ebekozien, for a phenomenal talk, and look forward to more meetings that include the American Diabetes Association. And as we talked about earlier, we may make this an annual Diabetes Awareness Month event. So thanks again to everybody.